Hello, everyone. Good afternoon. This is Kate Myers with the California Healthcare Foundation, and I'm so pleased to welcome you today to our SB1004 Technical Assistance Webinar, Topic 4, Gauging and Promoting Sustainability and Success. For those who may not have participated in our past webinars and workshops, the California Healthcare Foundation has been putting on this technical assistance series over the course of the last several months leading up to the implementation of SB1004 in January of this year. We've been very lucky to have our faculty, Ann Kinderman and Kathleen Kerr, leading us through a number of topics, including work on estimating potential patient volume and the baseline costs of those eligible for SB1004 in topic 1, estimating care delivery costs in topic 2, work on assessing the capacity for delivering palliative care in local areas and approaches to launching services in topic 3. And today, as I mentioned in topic 4, they will be focusing on gauging and promoting sustainability and success, strategies for tracking and evaluating the quality of SB1004 services, identifying potential barriers to program success and longevity, and how payers and providers can really collaborate to promote the delivery of high-quality palliative care. Our faculty, Dr. Ann Kinderman, is the Director of the Supportive and Palliative Care Service at Zuckerberg San Francisco General Hospital, and Kathleen Kerr is an independent consultant, lead of Kerr Healthcare Analytics. So as we are about to get started today, just a couple of housekeeping items. One is, I mentioned at the beginning, this is being recorded, so the recording will be available on the CHCF website probably early to mid next week. You can share that with your colleagues or refer back to it. And the slides from the webinar will also be available on the CHCF website. Because of the large number of participants, your lines will be muted during the webinar, and they are muted now. If you have questions that you think of either during the webinar or towards the end when we'll have a few minutes for questions, you're welcome to type those into the chat box. You can access that if you move your mouse. You'll see at the bottom of your screen along the webinar platform is a little bubble for chat, and you can hit that and then type your question into the chat box. With that, I will hand it over to Ann and Kathleen.
Hey, thanks, Kate. Kathleen Kerr here. I'm going to be getting us started. Next slide, Ann. So as Kate mentioned, we're into topic 4 of a planned 4-part series. And today we're looking at gauging and promoting sustainability and success. As Kate mentioned, I think I saw today Glenda sent out the webinar slides to everybody who was registered already, but those will also be distributed again along with the recording of this webinar towards the end of the week, if not early next week. When we're done with today's webinar, we still have to look forward to some workshops addressing the same topic, and we'll talk a little bit more about those at the end. And then we have a topic 5 that'll be coming along as well, where we'll look to get at lessons learned and adjusting programs. At that point, many of you will have been doing this work for at least 6 months. Others of you will have been doing this work for significantly longer than that. So it'll be a chance for us to look at how your programs are operating and what needs to be done to keep them sustainable. Next slide. For today's objectives, we're going to start out by just briefly looking at the information that the Department of Healthcare Services is asking all of the payers, all the plans to submit regarding their new SB1004 palliative care benefits and the services that are being provided. We'll then talk more generally about the resources that are available to measure palliative care quality. We'll go through some steps that you might want to consider as you're selecting quality metrics that you can use in your own program that take into account local needs and resources and challenges. We'll talk about some lessons learned around creating processes for routine program review and assessing the quality of your services over time. And then we'll close with reviewing a few lessons learned about factors that promote sustainability and scaling of services. Next slide, please. So very briefly, the Final reporting requirements, or the first iteration of the reporting requirements, have been released. That was done in February of 2018. I'm sure that all of the plans now have the Excel-based reporting template, including the instructions. At the moment, it's our understanding that quarterly reporting is required. And the reporting is pretty focused in the type of information that the department's asking you to submit, at least initially. There's patient-level reporting, so you do have to report on all of the patients that are receiving services. You'll give their name, their diagnosis, which are the 4 SB1004 diagnoses they have, the date that their enrollment or in a benefited program was approved, the disenrollment date, and the reason for disenrollment. So that tells you, how many and for how long. They're also asking for information about the number of referrals. So how many referrals to the program were made, how many of those referrals were approved, of those that were approved, and how many cases did the patients or the members actually accept the services, how many were declined, how many referrals were denied because they weren't eligible, and if they were denied because of a lack of eligibility, what was the reason why? What criteria did they not meet? And then finally, they're asking for some information about the network. So who are the providers that have been engaged to deliver SB1004 palliative care services? So the provider's name, the provider type, and that's there's a pull-down menu, and there's a mix of disciplines for individuals and also like types of services. So if it's a home health agency or a hospice or an individual, the specialty, if it's a physician, they want to know the specialty, and whether or not telehealth is being used in the delivery of care. This is all really good and useful information. It's good to know how many people are actually receiving services, and how many people was there a thought that they would be eligible, and of those where there was a thought they'd be eligible, how many actually were, and so on. But in addition to this information, there's a whole lot more you're going to want to know. It doesn't tell you anything, for example, about the quality of the care that's being provided. And that's one of the things we really want to emphasize today is, okay, you're delivering these services to your individual members. How do you know if the services are of high quality and if they're actually helping? Next slide. And one good thing to think about is as you're looking to go through the process of selecting some metrics, how would you know if the services that you're delivering are good and if they're helpful, is to think about sort of a general idea of, well, what is quality? What do we mean when we talk about delivery of quality of care? Many of you will recognize these as sort of the classic endorsed components, the variables that contribute to our conception of quality. So are the services that are being delivered, are they efficient? Are you avoiding waste? Are you being a good steward of resources? Are they equitable? Are you providing care that doesn't vary in quality because of personal characteristics such as gender or ethnicity, or geographic location or socioeconomic status? Is it, justice-based care? Is it patient-centered? So are you providing care that is respectful of and responsive to individual patient preferences and needs and values? And that's, really at the heart of palliative care. Is it timely? Are people having to wait a long time to access what they need? Are there harmful delays, or are you actually able to respond rapidly to the needs of your patients? Is it safe? So are you avoiding harm to individuals? Are they getting the type of help that they need? And are there secondary unintended negative consequences there? And then finally, is it effective? Are the services that you're providing, are they based on scientific knowledge and best practices of who would benefit from what? And are you refraining from delivering services that actually wouldn't be helpful or that might do harm? So when we think about quality generally, what would a quality service look like? Those elements that you're reporting to the Department of Healthcare Services, they're really important, but for the most part, they don't get at any of these variables. And I think most folks, whether you're a payer or you are a provider, would want to know about these different types of issues and whether or not the care that's being provided is quality care. Next slide, please. So the way that you do that, of course, is by assembling a portfolio of metrics that describe what was done and by whom and how often. So some sort of operational information, you'd want to know as best you can about whether or not the services that are being provided are being done so in a way that adheres to best practices, what's known to be best practices. And you'd want to assess quality from any number of perspectives, you know, in terms of providing quality end-of-life care or relieving symptoms, all those sorts of things. And one of the issues that we face in palliative care is that there are literally hundreds of metrics that are currently in use to assess the quality of programs. And the issue isn't really so much of, gosh, there's nothing that I can measure, but really narrowing it down to which amongst these, you know, hundreds make the most sense for me to measure. And there's a lot of places that you can look for metrics and then begin the process of determining if they're right for you and your program. We're going to highlight three strategies here for identifying potentially appropriate metrics. You can look at case studies or see what peers are doing. There's another service that's like mine. What are they measuring? You could also look at the approach that's being used in quality collaboratives, and we'll talk about one of those in particular that's focused on palliative care. And you can also look at metrics that have been endorsed by the field, by those that have done a very systematic and rigorous look at, well, what are the best ways of monitoring quality in this field of palliative care. Next slide, please. So metrics that were used by the California Healthcare Foundation Payer-Provider Partnerships Initiatives. Those of you who've attended prior webinars or been to the workshops, you may have heard us talk about this. This was an initiative that was sponsored by California Healthcare Foundation. It lasted all told, I think, about 3 years from a pilot phase to a planning phase to a 2 years of an implementation phase. And what happened here was there were 6 teams of payers and providers, sometimes multiple providers partnered with an individual payer, who came together to develop contracts for delivering palliative care services to a specific population. And we learned a ton from this project about what happens when you launch a new palliative care service. And one of the things that we learned was, well, what are the metrics that these folks are using? Which ones prove to be useful or feasible and all those sorts of things. And so I thought it'd be useful to share here today a list of the metrics that were being used by all of the participating groups. So there were 6 groups. No one group, no one team used all of the metrics that I'm going to be presenting here and that are available to you in these slides. But if you're looking for sort of a menu of different types of metrics that get at different types of issues, this is a perfectly reasonable set to choose from. We don't have time today to really kind of geek out and get into numerator and denominator definitions, but we'll do that a little bit more in the workshops, and we'll see about providing you some reference materials as well that would let you in a more detailed way assess the feasibility of these metrics. So to begin with, the operational metrics that folks are using, the number of patients referred, the percent where there were scheduled visits, and then of those scheduled visits, the proportion where visits actually occurred. The number of visits, average and range per patient in the enrollment period. So how many times are you actually having contact with the patient who's enrolled? The average number of days between referral and first visit. So that gets at that timeliness issue. Are you able to see folks fairly quickly? The average number of days between visits. So what's sort of the frequency of dosing that palliative care that you're delivering? The percent of individuals who are seen within 14 days of referral. So that's sort of a benchmark. That's a quality indicator for that, how long you have to wait between referral and the first visit. The referral source, the referral reason, and whether or not televisits were used in the delivery of care. And that might speak to that efficiency indicator. Next slide, please. So then different metrics that were used for screening and assessment, the percent for which a spiritual assessment is completed, the percent of individuals for which a functional assessment is completed, and I should say that these are things that could be assessed at both an individual encounter level as well as within each visit. Was this a visit that featured a spiritual assessment? Was this a visit that featured a functional assessment? The proportion of visits where symptom burden the findings of an assessment of symptom burden using the ESAS, the Edmonton Symptom Assessment Score. This is a tool that's used to look at many different types of symptoms, 10, I believe. And the teams that were using this did it on a repeated basis. They did an initial ESAS score, an ESAS score at a 3-week interval, and then an ESAS score at the 12-week enrollment mark to see if the teams are able actually to improve those numbers for the patient served. Are you making their symptoms better? Patient distress measured by a distress thermometer, again repeated at initial 3-week and 12-week visits to see what's troubling patients the most at any given time, and does that get better over time? And the percent for which medication reconciliation was done within 72 hours of hospital discharge. In terms of metrics that get at planning and preferences, some teams are using the percent of enrolled individuals where advanced care planning was discussed, and then the percent of enrolled individuals where an advanced directive or a pulse form was completed. Next slide, please. Many programs use indicators looking at the use of hospice and quality of, or characteristics of end-of-life care. So the proportion of individuals who remained on the service through the end of life, the proportion who died within 1 year of enrollment, the proportion where the individuals were enrolled in hospice at the time of death, the average and median hospice length of service, the location of death, and then I think a really useful indicator, the proportion of individuals who died in their preferred location. You can't really say what's the right percentage of folks who would die at home, but you can certainly say of those who expressed a preference for dying at home, how many were able to do so. Next slide, please. And then finally, utilization and fiscal outcomes, which we were not surprised by and had validated the idea that these are really important in these payer-provider partnerships. Quality efficiency is one way of measuring quality, and knowing that there's an impact on resource utilization and costs is really important for sustaining services. And there were several different ways that teams were assessing this. One method was to look at the per enrolled member per month cost of care, enrolled patients versus comparison population. So that's a pretty rigorous way of going about this. Another method that was used was a sort of a pre and post method where healthcare costs and utilization 6 months prior to enrollment was compared to findings 6 months after or in the midst of enrollment. And here indicators such as the number of acute care admissions, the number of total hospital days, the number of ICU admissions, the number of ICU days. So not only were you admitted to the ICU, but how long were you there, number of ER visits, and then different ways of looking at costs, total costs, inpatient costs, and outpatient costs. So these are examples of metrics that are actually being used by your peers, and for all I know, or I hope, in use by some of you who are on this call right now. And again, I'd stress that nobody's using all of these, but if you're looking at examples of things that are actually being used in the state of California right now to assess the quality of non-hospital palliative care services, these are some good items to choose from. Next slide, please. Another place where you can look for metrics, and actually a tool for supporting good measurement capacity or enhancing your measurement capacity, is to look what's being done by a QI collaborative that's operating here in the state of California, the Palliative Care Quality Network. It's based out of the University of California, San Francisco. And there's a lot to learn about this, and I'd encourage you to visit their website. But in a nutshell, it's a national learning collaborative that's committed to improving the care of seriously ill patients and their families. And they work with, or the members include, organizations that are providing both inpatient and non-hospital palliative care. There's a few large components to their operation. They have a patient-level data registry, so they actually have a infrastructure that's built that allows you to input information about each patient that was seen. You then have, as a result of participating and inputting information about your own patients, you can then access reports that allow you to look at your own performance and then to benchmark your performance against member sites, and you can do that by looking at sites that are similar to yours, for example. So only compare yourself to other hospices, or only compare yourself to other academic institutions, and so on. There's also a big focus on quality improvement. They have projects in education and case reviews. And then there's a big focus on community building. So there'd be a network of other provider organizations that you could interact with. At the bottom of the slide, you'll see the website for PCQ and also the name and contact information to Angela Marks, who's the person who can help to orient you to what they do. Next slide, please. Just to give you a flavor of what this looks like, this is one of 4 of the web-based data input screens that they use to gather information about individual encounters for individual patients. So you can, there's several ways that data can be uploaded, either on the individual level or through batch uploading. It's not simply based on having to do hand entry on individual patients. So if you're interested in having access to a platform and access to a group of folks who are all looking at a common set of metrics based on a common set of data elements, I'd encourage you to go look at the Palliative Care Quality Network website and see if that seems to be a good fit for you. Next slide, please. Another place where you could look for metrics that might be appropriate for your program is to look at, well, what are the experts in the field saying? What are those folks who spend their whole lives thinking about metrics and measurement and palliative care all simultaneously? What do they think about the right things to look at? And one good place to look is at the National Quality Forum. For those of you who aren't familiar with it, it's a nonprofit, nonpartisan organization, and they really exist for assessing what is the standard of care in any number of conditions or for different patient populations, and what are the most useful and rigorous ways of looking at quality for those different groups. So if you just put National Quality Forum into your favorite web browser, go to the section of their page that has measures, reports, and tools, you'll see this little funky entry under measures called Check Out QPS. I put a little arrow there for you. But if you click on that, it'll go to their quality positioning system, which basically is a compendium of all the metrics that their organization has endorsed for any number of conditions or care settings or patient populations. Next slide, please. Excuse me. When you go to the QPS, you'll see that there's a little search box, and I entered palliative care into that. I also went down into that left-hand menu and said that for palliative care, I only want to see outcomes that are intermediate clinical outcomes. And I hit the little search button, and lo and behold, up came these 3 metrics, each of which is really useful in its own way. Proportion of patients who died from cancer admitted to hospice for less than 3 days, proportion of patients who died from cancer admitted to the ICU in the last 30 days of life, and so on. If you don't hit any of those sort of narrowing criteria, you'll see that I think there's currently 31 metrics that are deemed appropriate for hospice and palliative care that are included in the QPS. You can also find out information about how they're defining the numerator and denominator. You can see the evidence that was reviewed to support the use of an individual metric. You can see what they call the measure stored, so the organization that suggested that this was a good metric to use for this particular population. The 3 that are on the screen were all suggested by the American Society of Clinical Oncology, so they're pertinent for cancer patients, though several of them are, I think all of these actually would be really appropriate for other populations as well. So I'd encourage you to check out the NQF QPS system if you want to get a sense of what are the metrics that have been endorsed nationally and that are being used at the state and federal level in many instances for assessing quality. Next slide, please. And then finally, I want to point you to an initiative that was sponsored by the American Academy of Hospice and Palliative Medicine and the Hospice and Palliative Nursing Association, the Measuring What Matters initiative. This was a really cool and ambitious effort where they brought together a lot of people who had expertise in palliative care, expertise in research, and expertise in selecting and using metrics and measuring the quality of care. And that they came together and endorsed a list of 10 measures that they felt would be appropriate to use for multiple patient populations in multiple settings, and that if everybody who was doing palliative care started to look at things, we'd be able to get a much better sense of what was going on in the field. There's some terrific journal articles that you can access from this page. You can look up the history and how they came up with these measures. But also, if you click on that actual measure list link or the measure concepts list, you can get a look at, well, these are actually the 10 that this big group wound up endorsing. Next slide, please. And you'll pull up a list that looks like this, the top 10 measures that matter. They'll list each one of them. They'll talk about, give a little bit of information about the numerator and denominator. They'll tell you about the source, and they'll give you a web link to learn more. One thing I'd say about these is that I really like all of them. All 10 are great, but many of them were developed for, say, the inpatient setting or for the hospice population. Nonetheless, they all, nearly all of them, would be appropriate for use in a community-based palliative care program. And so I personally would be comfortable using any of them for, say, a home-based program, even in the setting where a measure was developed for an inpatient service, with perhaps a little bit of a tweak to how the, say, the timing. You know, if you have a community-based program, you would get rid of any criteria that have to do with within 1 day of admission to the hospital. But otherwise, for example, screening patients for physical symptoms is a very good way of, that's an important process measure to show that you're attending to pain, and I think that's appropriate for a community-based program as well. Next slide, please.
All right. Yes, that is. Not me in the slide, but this is where I take over for a little bit. So Kathleen did a really excellent job of walking us through all the different ways that you could look for quality metrics and what other experts in the field are recommending, and what other programs in California are doing. I'm going to speak more from the perspective of a palliative care provider who, you know, wants to know, are we doing good work, and how would you go about selecting from these literally hundreds of metrics that are out there. So there are a few things to consider when you approach this. A key component is what matters to your stakeholders, then thinking about how feasible is the data collection going to be, and then thinking about your measures as a whole, all the metrics that you're using. Do you have balance in your portfolio of measures that are going to really tell a story about the program and the different impacts that the program has? So first and foremost, I think it's very important to not just do this process of selecting metrics in isolation. It's really important to think about who are the stakeholders that are going to be important in thinking about, is your program successful and sustainable? And I think about that in different categories. So first of all, you have a set of internal stakeholders. So if you are a plan, you know, the people who are clinically oriented within the plan, or if you're a provider organization, the actual on-the-ground clinicians and folks who are answering the phones and responding to patients and families, et cetera. The folks who are financially oriented, how is this program going to continue to provide services? It's going to matter a lot to the folks who are involved in finances at any organization. And then regulatory, so the people who want to make sure that you are doing everything that's required of you, both from the perspective of the state or from the regulations of the type of organization that you have, or you're doing work that matches up with that. Externally, thinking about, most importantly, whoever your partner is, whether that's the managed care plan you're working with or the palliative care provider that you're working with. They need to have conversations. This partnership around what matters and how are we going to know that this program is working. You want to, of course, think about your referring providers, because if you don't think about what their interests are and their needs are, people may not be interested in referring to you, and the program isn't going to go anywhere. Thinking about your community partners, other people who might potentially identify people who are interested or who would benefit from palliative care, who they recognize maybe earlier than referring providers might, that palliative care might be of benefit. So getting at what would be in their interest. And then, of course, you want to be paying attention to what the Department of Healthcare Services says in terms of the type of metrics you're going to look at. When you then decide on who you want to reach out to and talk to about your metrics and how we're going to define quality, we came up with some questions to think about in this conversation. So probably most importantly are the top two around what would a successful palliative care program look like, and what are you hoping that the program will achieve? And I think I cannot stress enough from my experience as a palliative care provider that you will get different answers from different people in terms of what they're hoping for and what their priorities are. So making sure that you get a sense of what people are looking for in this program. And a way to, there may be a whole laundry list of things, some of which may be possible, some of which may not be possible in terms of looking at program outcomes. To help focus people, asking them, if you only had one measurement of program quality, what would it be? So then you can kind of get a sharper idea of what are your top priorities in measurement. And then lastly, thinking about how might the palliative care program impact or be impacted by other programs. No one is going to be doing this work or referring patients in a vacuum. Everyone else has other things that they're thinking about and worried about. You want to think about the unintended consequences or ways that the palliative care program might be affected by other things that are going on, or vice versa. Next, after you've had those conversations, those kind of foundational conversations with your stakeholders, you really want to dive in and think about the list of metrics you're looking at and ask the more specific questions around where would you actually get the data? Is it available in the electronic health record? Or if it's not available in the electronic health record, could it be collected specifically for this purpose? And this is something that, because in our example at San Francisco General, we can't pull information very easily from the electronic health record. So all of our information is collected specifically to be very judicious about how labor-intensive that collection process is, and the very nitty-gritty around who would be involved in the data collection and how much bandwidth do those stakeholders have to take on new tasks. Particularly if you're going to be doing a home-based program where providers have travel time and they're doing lots of other things, adding on pieces of data collection may really have a palpable effect on their workload. Then you think about, would the data be consistently available, particularly if you're going to be pulling it from another source? And how reliable would the data be if you're mining it from electronic health record and you haven't actually entered the data yourself? And then thinking about the practical aspects around where and how would you house the data? What type of a system would you use? And who would be entering it? And then what would the analysis process required? Would that require a lot of analytic work, or is it a simple report that can be generated and pulled easily? So the last component is really thinking about aiming for a balanced portfolio. So this picture is really thinking about, we think about our investment strategies and other things in this way of having a mix of different things that you're investing in that have short-term and long-term returns. And you don't want to put all of your eggs in one basket just because things can happen to any one of these sources. So similarly, for metrics, you want to think about having a balanced portfolio of metrics. Of course, it's a little bit different than thinking about investments. So how do you think about balance in this case? So first, you want to think about what are the different types of metrics that are out there. So Kathleen alluded to this when she was talking about the background on different types of metrics. So the metrics that you will look at will point at different components of either structure, looking at the team and how things are done. This is more kind of background, looking at the quality of how the services are delivered. The process, what is done on a day-to-day basis, and the workflows and those things. There are a lot of quality metrics that look at things being assessed at certain times. The measures that Kathleen mentioned around doing symptom assessments by certain points in time, those would be examples of process measures. And then lastly, outcome measures around things like reduction in pain by a certain time, or the financial impact of the program. Those are hard outcomes that you will find in addition to things that could be on the more qualitative side in terms of patient or family satisfaction. Those would be outcome measures as well. You want to have balance. You want to think not just about these different types of metrics, but also balancing different focus areas. So thinking about metrics that speak to the patient level outcomes or family level outcomes, programmatic level pieces, and then how it impacts the system. So thinking about all those different buckets, it's important to include as many of those as you can. And then lastly, thinking about balance, you have to be practical. You have to think about how much effort is going to be required to collect and report on each of these items. And I would encourage you to think about this in terms of if you're going to have measures that are going to be more labor intensive, it's important to think about a manageable number of those more labor intensive measures and balance them out with things that can be generated relatively easily. So when we put this all together, you might do something where you look at each metric and then look at, is it a structure, a process, or an outcome measure? Is it something that's important to the plan? Is it important to the provider? Or is it important to another stakeholder? And then finally, is it easy to collect? For each of these measures, in terms of the importance and the collection pieces, you would want to enter in how strongly this fits. So is it not of interest or hard to collect, ranging to something that is very important to someone who's involved and very easy to collect? Those would be much more favorable ones. You want as many with a plus as you can. And so when you look across this whole spectrum, if you see a metric that doesn't have at least 2 of the plus signs, then you should really reconsider whether that or not that's something that's important for you to look at. After that background, I just wanted to walk you through how we have done this at San Francisco General. And we've done this both for our inpatient and our outpatient programs. So we have these 2 programs. We have an inpatient consult service, and then we have an outpatient service which provides clinic-based palliative care, and then also moving into telehealth palliative care. And we have patients that are seen by both services. We have patients that are just seen by the inpatient service. We have patients that are just seen by the outpatient service. So ideally, it would be nice if you had a means to look at outcomes across sites because we're ultimately providing care in all those places. For us, as I mentioned, we unfortunately have electronic health record that is very difficult to pull information from. So from the very beginning, we have been generating all of our program level data by stuff that we collect by hand. And that is an unfortunate reality for us right now that hopefully will change in the future. But I'm here to say that you can do that, and that it's not ends up being not as cumbersome as you might think. And the last piece is that we have limited administrative support. So for the first 7 years of our program, we did not have any dedicated administrative or analytic support. So we had to do all of this really on our own. The clinicians were involved. The key stakeholders that we wanted to think about are system leaders. So our CEO, our CFO, our chief medical officer of our network, our head of specialty care, our heads of primary care. What are those, the priorities of those groups? And then we need to talk to our inpatient and outpatient teams, the people who are actually doing the data collection and doing the clinical work. What's meaningful to them? What would success look like to them? Externally, we have San Francisco Health Plan as a key partner that we work with, particularly around SB1004 and what's of interest to them. What does success look like? And then we have some important grant funders who have supported our work, and some of them have requirements around what we're going to generate in terms of data reports. So walking through the process, the steps that we took were first to start with this preliminary discussion of our program goals, kind of a bigger picture discussion with stakeholders around what a successful program look like, and are there any specific outcomes that would be very important to our different stakeholders, just to get kind of a preliminary sense of where our different stakeholders are at. From that, for us at the the palliative care provider level, we really had to do a feasibility assessment. Because of the limitations of our EHR, we had to see whether some of the data is even available or attainable. And then for things that we already were collecting for, that we knew we had to collect for our grant funders, is it something that's already there, that's easy, versus something new that we would have to add in? That's something to consider. After we then had a much shorter list of metrics that we thought would be appropriate and would really speak to the priorities of our stakeholders, we took that list back and kind of reviewed it and said, how does this look to you? For our quality measures for particularly our clinic-based services, took a look at it to make sure we had a balanced portfolio speaking to different focus areas and different types of metrics, and then got into the weeds around what would the collection and analysis workflows look like. And it's important to say here, so, of course, I have my perspective of working from the palliative care provider perspective, but I know that some plans are doing this work themselves and saying these are the metrics that we would like our palliative care partners to do. And you can kind of start this at any point, really, in this three-part process. But it's important to have those communications that are bi-directional, particularly around things like feasibility and importance of certain outcomes or measures. So for us, if we were to fill out this chart, these are just a sampling of some of the metrics that we're using. So looking at the metric around, is there an interdisciplinary team and what proportion of the clinicians are palliative care certified? So that's a structure outcome. It's particularly important to our plan in the sense that SB1004 requires an interdisciplinary team. It's very important to us in terms of delivering high quality services and being able to meet the complex needs of our patient population at a county hospital. It's important to other stakeholders, like, for example, the Joint Commission, who certifies palliative care programs. Fortunately for this metric, it's quite easy to collect because this is just the structure of our program. You can look at these other aspects as well. It's worth mentioning that something like screening for psychosocial distress is a measure that helps us be accredited with the Commission on Cancer. So it's something very important for us to have helped our oncology colleagues to implement. So once you've selected your metrics, you want to think, discuss that, take it back to your stakeholders, and think about your targets. Is there a specific target for each metric that you're going to try to achieve? And if so, what are you basing that target on? You want to be as well informed as you can by what's feasible other places. And then what would happen if that target isn't achieved? You want to be clear on your interval for reporting, both to your internal and external stakeholders, and what format the reporting is going to take. What type of preference around communication do the different stakeholders have? Is it email? Is it in person? Is it remote? Those are all different options that different programs have taken. So for promoting sustainability, we have these 4 main recommendations that I'm going to go through one by one. So a wise person once said prediction is very difficult, especially about the future. I thought this was Yogi Berra, but apparently Niels Bohr was the first person to say this. And it's, of course, it's funny because it seems obvious, but I think it's important to say as you're starting programs that it's really hard to know how things are going to go in your particular environment with your patient population, with the way that your program is structured. There are a number of things that are hard to predict, like where the referrals are going to come from and how much marketing and outreach will be required, which patient populations will be the largest. So are you going to suddenly have a couple of cardiologists who think that palliative care is the greatest thing ever, and suddenly your population is dominated by heart failure patients and their unique needs? You may not be able to predict the way that roles and responsibilities of different team members are going to evolve, how workflows will change, particularly if you change your venue, whether you're seeing patients in clinic, at home, or by telehealth, how many patients you're seeing and the mix of staffing that you have. And then it's hard to know your projected versus your actual costs, of course. And it's worth saying that most successful payer-provider partnerships include this concept of routine reevaluation of program goal structures, workflows, and outcomes. This is an example of a program that started off with an expectation that there would be 2 nursing visits per patient per month. But as the program actually got going, they noticed that some patients didn't make themselves available for the scheduled visits, or they didn't really need nursing visits regularly. They needed a mix of other things like social work visits. So the conversation then between the plan and the provider were to talk about waiving or adjusting the requirements for particular patients or circumstances, or having different phases of the program where there would be high intensity and less intensity phases. The next key recommendation is to have routine communication, as we've mentioned. The reason this is important is that there are changes in staffing and things that happen. You need to talk about both clinical and operational factors, and then again, what's the best mechanism for communication. You need to do the needs assessment again, even though you've done it before. When there are changes, like changes in key partners or stakeholders, when your program expands to a new venue or a new patient population, you need to think about what are the priorities of your stakeholders again, and then thinking about changes in scope of work or responsibility for the program. Those are all times where you would want to repeat discussion with your stakeholders around what's important to them. With that, I'll hand things back to Kathleen.
Yay, thank you. So in thinking about, this issue of revisiting your needs assessment and ongoing communications, a big reason why that's done, a big reason why you look again at what you're trying to achieve and how you're doing is a big challenge for these palliative care programs. I think in particular for the community-based ones is achieving balance across three areas, all of which are important to both the payer and the provider just from different perspectives. So you want to make sure that the scope of services that you're providing and the effort that's required to deliver those services is aligned with the amount of payment that the provider is receiving so that they can actually sustain this work and so that they can feel like they're being treated fairly. And at the same time, that payment and output on the part of the plan needs to be justified by outcomes that justify the investment, that they're achieving what they need to achieve given that investment of monetary resources. You know, and if any one of these three things is out of whack, it can really be a big blow to the sustainability of the program. And so it's worth revisiting this and accepting that if things will change over time. You know, as Anne was saying, as you scale a program and you go from treating, you know, maybe 20 patients in a 3-month period to treating hundreds of patients in a year period, some of those processes that really impact the effort required to deliver care or to administer the program, they could balloon to the extent that the amount of payment is suddenly not keeping up with them. Or new efficiencies may be introduced that mean that the payment may be could be adjusted in a different way. So as you think about how your service is going to scale and how you're going to sustain it, keeping these three touch points in mind will be really useful for you. Next slide, please. The last focus area of sort of promoting sustainability and supporting scaling, we wanted to pull again from these lessons learned from the payer-provider partnership initiative and spend a few minutes talking about relationships and the relationship between the payer and the provider. And what we saw from the program participants and what I think many of you may have seen in other aspects of your professional life is that even if you have a really great service or a really great program, if the relationship between the partners is bad, that program doesn't stand a chance. And I'd really encourage you, even at this time when you're thinking about sort of the nuts and bolts of how processes are put in place and what your workflows are and what your metrics are and how things are turning out and if the payment is enough, all of those sorts of things, is to really attend to that relationship between the payer and the provider. And if that's good, then you can likely navigate any of these challenges that come up if your program gets out of balance. If the scope and the effort and the payment and the outcome somehow become misaligned, you can weather that if you have a good relationship between the partners. And there's a couple high-level points that guide these relationship issues. One is that seems kind of obvious, but it's worth repeating, is that listening and transparency and empathy and collaborative problem solving, those are all highly valued amongst the folks who participated in the initiative. And conversely, inflexibility was seen to be, kind of a huge red flag. The other thing that I'd point out that I hadn't thought about before we talked to people and what their experiences were is that organizational culture influences relationships. And if you're part of a relatively small organization, you're used to walking up the hall to talk to a CEO, or you're sort of small and nimble and you can make decisions quickly, that may not be the case if your partner is a large organization, where the CEO may be in a different state. It may be somebody that the person who you've been in contact with never has contact with, or if you have to go through a 6-phase committee approval process to make a change, or if email is preferred, or in-person is preferred, or video conferencing is preferred. So just be aware that it's not just the individuals that are interacting with each other, but that organizational culture will also need to be accounted for and shown empathy towards, and appreciate how that can influence the quality of the relationships. Next slide, please. At the close or close to the close of this project, we asked a whole bunch of people about, what is the most important characteristic that you look for in a partner if you're looking to develop a community-based palliative care program? And here we had the payers and the providers echoing each other, but just from a different perspective. A quote from a provider that we interviewed is, they'd look for in a payer partner somebody that was collaborative and flexible and able to appreciate the perspective of a small partner. And a quote from a payer that just really sort of mirrored this was, ideal characteristics would be an ability to take in information from many perspectives, including an ability to appreciate the perspective of a payer partner. There's a recognition that this is a negotiation and it's a partnership. There is, for lack of a better word, an adversarial quality there, or at least a difference in the type of organizations, and showing that you can appreciate the perspective of the person who's sitting on the other side of the table is super important. Next slide, please. You know, and as a companion item to the what would be the most important characteristic you look for in a partner, we asked about, you know, what characteristic might be a predictor of a poor fit. And one of our providers gave what I thought was a really intriguing quote here, stating that as we brought issues to the forefront, big and small, the plan was always willing to engage in a conversation to hear our perspective, how a contract requirement might impact care. Even if the plan didn't agree, it was important to us that they were willing to have that collaborative conversation. Not seeing this kind of openness would be a huge red flag. A payer that just says, this is the way we do it, would be a difficult partner. So the lesson here is that just because you have the conversation, you don't have to agree with everything, but it's so appreciated to be shown the respect of having your needs heard or recognized, that really creates a lot of value, and not seeing an ability to do that would create a lot of fear, create a red flag in a potential partner. Next slide, please. And then finally, we asked about this issue of bridging organizational cultures and perspectives. You know, there's differences of where payers and providers are really different types of organizations, and you're going to have to do some, you know, sort of cross-cultural work to be able to interact with each other better. And this is one of the offerings, one of the quotes that we got from a payer that we interviewed. We were very successful in educating each other about our organizations and in being transparent about priorities, risks, and benefits. The foundation of these successes was a willingness to trust, a belief that the person or group on the other side of the table is not going to take advantage of me. This trust had to be earned and then reflected in the contract. For example, the contract included language that allowed the provider to bill for services outside the set PMPM rate in instances where a specific patient needed significantly more than the expected amount of support. So here, this is sort of a contractual expression of trust. The provider was shown trust or could feel that the payer partner was trustworthy because it was recognized that the PMPM might not cover everything, and there was an avenue for securing more revenue to cover those expended resources to cover their effort. And the payer, you know, showed a lot of trust in saying, yeah, you know, we realize that there will be variability. Here's a set rate that we're comfortable with, but we'll create the opportunity for you to bill more in instances where that's appropriate. So just keep in mind that there's two perspectives for every agreement, and if you do that, you're likely to be more likely to have success. Next slide, please. So in summary, supplement the information reported to the Department of Healthcare Services with with structure, process, and outcome metrics that describe care quality. When considering metrics, look to what your peers are using, look to the items that have been endorsed by professional organizations, and consider what QI collaboratives like the PCQN are doing to assess quality of care, and consider taking advantage of the benchmarking opportunities that exist in a collaborative like that. The right metrics are those that are feasible and that meet the information needs of both parties. So there's no one set of metrics that's going to be right for everyone. And just because you started doesn't mean you're done. Remember that there's going to be ongoing monitoring and modifications will be needed. You'll need to revisit your goals and your objectives, and you'll need to reassess needs. And then finally, be sure to prioritize creating and sustaining good payer-provider relationships. Next slide, please. And with that, we've just about hit the end of the hour. We want to thank our colleagues who shared their wisdom and their knowledge and their experiences. We'll remind you that we're going to have 4 in-person workshops on this topic. There'll be, the total time is about 4 hours, including break. There'll be 2 in Northern California on April 23rd and 25th. Those will be in Oakland at the CHCF offices. There'll be 2 in Southern California at the Garland Hotel in Los Angeles on the 27th and the 30th. If you have questions about SB1004, we encourage you to visit the webpage that's maintained by the Department of Healthcare Services, and they also have an email address that you can use. And finally, if you have questions about the Technical Assistance Series, feel free to get in touch with Kate Myers. And with that, I'll hand it back over to Kate to close.
Thank you so much, Kathleen and Ann. And I know we have reached the end of our hour, but I would encourage anyone who had a question that they had not yet typed into the chat or Q&A. We didn't receive any, but if you were holding on to them, hoping for a few minutes at the end, please feel free to email those to me at the email address right there on your screen, kmyers@chcf.org. And we'll try to get those answered for you offline, knowing that some folks will have to log off right now. But again, thank you so much to Kathleen and Ann, and I'd encourage anyone who wants to dive deeper into this content to look at your availability to attend a workshop. We will be distributing information about the workshops and how to register probably by either tomorrow or early next week. So keep a lookout for that in your email, and if you're interested in attending, please do register early. They may fill quickly, so we encourage your teams to consider attending if you'd like more time and more opportunity to interact with Kathleen and Ann on some of these important questions and issues. With that, we will sign off for the day, seeing no Q&A and chat questions coming in, and encourage you again to get in touch offline if you do have any burning questions you'd like to address. Thank you again, Kathleen and Ann, and thank you all for attending.